What is that murmur? A case of culture-negative endocarditis by Cheryl Saxena, Zachary Hansen, and Dr. Sil J. Patel. The learning objectives for this clinical vignette are that subacute endocarditis can present after the initial infection has cleared, negative blood cultures do not always rule out endocarditis, and that all newly discovered murmurs ought to be investigated. This case begins with a 71-year-old female with a history of aortic repair who presented to cardiology clinic for follow-up after hospitalization for acute dyspnea. TTE during that admission revealed mitral regurgitation, flail segment, and an EF of 35%. At the time, patient denied any symptoms of edema, palpitations, angina, fevers, chills, or fatigue. Subsequent TTE showed a 1.1 by 2 centimeter vegetation on the posterior mitral valve leaflet and moderate to severe mitral regurgitation. Unfortunately, this patient's course changed. She was scheduled to undergo outpatient workup but had to be readmitted for recurrent shortness of breath. She still did not have any fevers or signs of infection. All sets of blood cultures were negative throughout the admission. She was found to have dental caries, so initially it was thought that the vegetation was a result of prior endocarditis that had been cleared. Oral surgery extracted 3 teeth. In preparation for the valve replacement, catheterization was performed and 3-vessel disease was found. Thus, mitral valve replacement with coronary artery bypass was planned. ID was consulted, and they recommended a short course of antibiotics. She ultimately underwent bioprosthetic replacement and coronary artery bypass. However, during the surgery, the vegetation was not visualized. Instead, only small wispy filamentous attachments on the posterior valve leaflet that were too small to be sent in for pathology were seen. After the surgery, an infarction of the superior cerebellar artery territory was found, and it was speculated that the vegetation had embolized prior to visualization. Unfortunately, she deteriorated in the days after and passed away on post-op day 6. So from this case, we learned a few things. We learned that though infective endocarditis is thought to present acutely with fevers, positive blood cultures, and new murmurs, this case demonstrated that it can present subacutely after the initial infection has cleared, when a patient either did not have symptoms or failed to recognize them. Blood cultures reveal the underlying organism in 93 to 98% of cases, and the rest are usually negative due to reasons such as previous antibiotics, improper culture techniques, or infection with fungal or zoonotic organisms. Careful history taking may elucidate exposure to livestock, immunosuppression, or travel, indicating exposure to Bartonella, Coxiella, Histoplasma, or Aspergillosis. The outcome can be an asymptomatic yet sterile vegetation that requires surgical intervention but no antibiotics. From this case, we concluded that clinicians should investigate all newly discovered murmurs, as not all endocarditis cases can present acutely with fevers or clinical signs and can occasionally be the sequela of prior infections. Patients with a history of dental caries should be auscultated regularly to detect early or subacute endocarditis, despite lack of symptoms. Indication for surgical therapy for these vegetations will depend on presence of symptoms, size of the vegetation, residual valve function, hemodynamics, as well as other patient factors. For additional information, please contact Cheryl Saxena at cheryl.saxena@northside.com. Thank you.